Hi, I am Ahmed Mustafa Abdurrahman, Professor of Ophthalmology and Glaucoma Consultant, Cairo University. Over the next few minutes, I will try to demonstrate the practical applications of the available evidence for the management of angle closure glaucoma. This is a gonioscopic demonstration of the angle closure, where there is a contact between the peripheral iris and the trabecular meshwork for 180 degrees or more. The foremirror gonio lens is important during examination. It induces indentation of the cornea, and in the video here, the iris was convex, hiding the angle structures, and upon indentation, we can see the trabecular meshwork. In the lower photo, we can see extensive peripheral anterior synechiae, which is important for the classification of subtype of angle closure. Primary angle closure is further subdivided into primary angle closure suspect or PACS and primary angle closure and primary angle closure glaucoma, which is further subdivided into acute angle closure crisis and chronic angle closure glaucoma. And all those subtypes are related to pupillary block mechanisms of angle closure, while plateau iris syndrome represents non-pupillary block angle closure mechanism. In primary angle closure suspect, gonioscopy shows two or more quadrants of iridotrabecular contact, no peripheral angiosynechiae, the intraocular pressure is normal, and the optic nerve doesn't show evidence of glaucomatous neuropathy. And in this situation, there is no evidence to support any kind of intervention in bilateral quiet eyes. However, if an eye sustained an attack of acute angle closure glaucoma crisis, then it is strongly recommended to perform laser peripheral iridotomy in the fellow eye. Primary angle closure shows the following features: two or more quadrants of iridotrabecular contact, peripheral anterior synechiae and or elevation of the intraocular pressure, and no evidence of glaucomatous optic neuropathy. In this stage, phacoemulsification offers the best long-term intraocular pressure control. If we are going to do PI, meticulous follow-up is needed as the pressure might rise again. This patient presented with primary angle closure, and laser PI is seen to the left through the transillumination, but the patient on the follow-up reported progression of the visual field due to inadequate control of the intraocular pressure. Primary angle closure glaucoma shows contact between two or more quadrants of the peripheral iris and trabecular meshwork. The intraocular pressure is usually elevated with evidence of glaucomatous optic neuropathy. If the patient presents with an acute attack, then medical treatment is initiated. This is followed by phacoemulsification or laser peripheral iridotomy. Now, in patients with chronic angle closure glaucoma, there is a strong evidence that phacoemulsification is the first treatment option as it treats the cause. Other debatable issues with less evidence including goniosynoculitis or viscosynoculitis, trabeculectomy, especially when the optic nerve shows advanced damage, and repair of the pupil. Plateau iris configuration patients usually present with an acute attack and receive a PI, and then they get other attacks after the PI. The diagnosis is confirmed with the UBM, where we can find anterior rotation of the ciliary processes. These are the take-home message that angle closure disease is common, categorizing the patient into PAC or primary angle closure glaucoma is important. Anterior segment imaging UBM can differentiate between pupillary and non-pupillary block mechanisms. Laser PIs are helpful in PACs and PAC, but follow-up is important and some patients might require medications. Cataract surgery has the strongest impact on the long-term intraocular pressure control. It is technically challenging and better to be done by the most expert surgeons. You may consider other surgical options according to the case, like adding trabeculectomy or goniosynoculitis. Thank you very much. Please feel free to communicate through the email in case it is needed.